On-the-scene coverage of ACC.14 is supported by Janssen Pharmaceuticals, Incorporated.
I'm Peter Block for On the Scene here in Washington, D.C. at the ACC annual meeting. I'm here with Chris Cannon. Chris needs no introduction for anyone in the ACC, and we're sort of wrapping up today, Chris. We've seen a lot of late-breaking clinical trials, interesting hot topics, the partner business versus whether core valve is better than partner and all that stuff with the new core valve data. And I think, for me, candidly, scientifically, the anti-PCSK9 antibody, interesting data from 3 trials.
Yeah, well, it is a very exciting time. I think there are 3 trials out of a program of 9 with just one of the different agents and a whole flood of them coming to evaluate at this point, how much LDL reduction there is, and it's astounding. It's greater than 50%, and taking LDLs down to depths we've never heard of, and in fact, sometimes people get nervous that they're so low. But, one of the studies was in familial hypercholesterolemia, where we really need new therapies. And so very, very exciting, terrific safety profile, and uniform results in just every possible patient so far, these huge reductions in LDL.
Right, we're seeing LDLs in the 30 to 50 range. That is sort of the dream of the cholesterol gurus, right? Can we get cholesterol or LDL cholesterol down that low? And it seems, when you're born, it's that low, and maybe that's the way we ought to live. But this is the first time we've really gotten there.
Yeah.
So for me, the question is, okay, now what? Yeah. Right? And I think that's the next trial.
Yeah. It's a very good point that the outcome trials are underway. There are 2 large ones that are actively enrolling with different agents, and so that will say whether this huge reduction in LDL with a non-statin drug is of benefit. And then the other group that we've mentioned are the statin intolerant patients, where despite multiple tries usually, and we've all had patients like this, that they can't take a statin. This could be an ideal treatment.
These are the people that get the muscle aches and so forth. For the cardiologist taking care of statin intolerant patients, this is going to be a major breakthrough, I think.
Yeah.
Exciting.
Yeah.
Let's move on. Core valve data. Give me a quick shot at this one, Chris. What do you think?
Well, of course, I'm not really, shouldn't be speaking of this, but as a referring cardiologist, this is the second, expandable TAVR device, and the data looked really good. I mean, a benefit relative to surgery on mortality is just huge.
The mortality at surgery for these patients was 5%. At 30 days. That's an extraordinary number. The surgeons did remarkably well. Interestingly, the surgeons did very well in the original Edwards trials as well. And so it's clear that the surgeons are learning a lot about how to take care of very sick patients that have aortic stenosis. At 1 year, the outcomes in this trial were 19% versus 15% mortality. I mean, somewhere in the range of the high teens. That's less than what we saw with the Edwards trials early on. Of course, they're different devices. But nevertheless, for me, Chris, it tells me not so much that one is better than the other. I don't think you can make this comparison. It's just not fair at this point.
Right.
And probably we don't learn a lot, but for me, it tells me here we are 7 years later, and we're learning better how to take care of these really sick patients that have aortic stenosis and lots of other comorbidities. And that is a huge step forward.
Yeah.
Now, ultimately, I guess we're going to try and figure out whether you should use one for one patient and one for the other and all those other things. But for now, I think this is all positive. I'm delighted with these data. I think that it tells us a lot about paravalvular leak going forward, mortality at 1 year, and so forth. Exciting, good for people who are excited about TAVR, and I think very supportive for patients that have aortic stenosis. So let's move on to the third topic, the Simplicity trial, Chris. Simplicity came out now almost 2 months ago, a bombshell, a negative trial for renal artery denervation, and it was presented today by Deepak Bhatt. Did Deepak shed any further light on this? What do we know?
Well, interesting. We obviously see the data, it's published and very nicely done to see that in a randomized trial, this had a sham control, very well managed patients. So on multiple classes of drugs, obviously carefully monitored, that there was a pretty good improvement in the blood pressure in the medically managed patients who got a sham intervention, and that's probably the story. There was a good reduction in blood pressure as well, but not a significant difference. I think there's not a clear answer of, oh, here's why it looks so good in the prior studies and no benefit on blood pressure reduction. But it's been raised that other devices with more complete renal denervation might do a better job, or different setting, perhaps different patient populations of truly resistant with a different phenotype might be those who benefit.
For me, Chris, the data from the surgical sympathectomy stuff back in the 70s and 80s is so compelling. Those patients really did drop their blood pressure. There's something there. I can't believe this is going to disappear. My sense is we're going to see some more trials, maybe different devices, and if it turns out the same way, then it turns out the same way. But hopefully we will ultimately see something that makes renal denervation a possibility for hypertensive patients.
Yeah, well, certainly the first statin didn't work out, but the second, third, fourth, fifth, sixth, and seventh did. So
stay tuned.
Stay tuned, yeah.
Thanks.